this project actually is an extension of a previous project that we have done with Toowoomba Hospital. And unfortunately I broke my leg after presenting that project, so you have to bear with me. But anyway, I'll tell you about this story. This is a story that's evolving. It developed from what was called the TULIP project, which was Toowoomba and University of Southern Queensland Learning Investment Project. And that was founded with some Clinic Q money that was around a few years ago. So it's been actually an evolving project that's now created sustainable placements for us and quadrupled our placement numbers, which was a byproduct, not one of our aims at the time. So it created what we call an investment project, and that developed a framework for us that builds on capacity and capability. It doesn't focus on capacity, it focuses on capability. And we hope or anticipate from increasing capability of staff and preceptors that we end up with an increased capacity. So as I said, it's an extension of that TULIP project that was conducted in the acute care sector, so within our med-surgical placements. It's been going now for 3 years. We're heading into our 4th year and final evaluation year. It's still being very well supported, and even through all the changes that have occurred in the health sector over the last 12 months, we've actually grown placements and continue to grow placements even as of yesterday. So it's still sustaining. So the framework is actually, we believe, working, and that'll be the evaluation next year to determine that. The project utilises what we call the how-to guide. It's based around the risk management principles of doing an assessment, looking at what people have to say, putting an implementation plan in and then evaluating it. So it follows that action research. It's about staff engagement and it's about staff involvement, and it's also about student involvement and what they have to say as well. We link whatever we've done and whatever initiatives come out back to the literature, just so that we can see, is there anything new coming through, or is what's happening and what staff are saying they want really and truly supported in the literature. So our project aims were to improve the placements, and I don't mean that just in pure numbers, I mean that as in the learning experience. So it's to improve the learning experience of students while they're on a mental health placement. And that was through that introduction of the TULIP implementation plan, which I'll go through with you in a minute. It also was to look at capacity. One of the areas that we very much struggle, I think, along with every other university, is in capturing and getting great learning experiences within the mental health sector. It's a bit of a twofold venture. We have a lot of specialty sectors within mental health that want to take postgraduate level, and there's very valid reasons for that. We have a lot of students very apprehensive about entering into the mental health area to do placement. So there's a lot of difficulties on both sides of the fence there. So it was about understanding that a bit better as well. And the big one that kept coming to us was what educational opportunities are there for mental health nurses in increasing that teaching capability. Often within that mental health setting, it's one-on-one mentorship. They're community-based settings. We talk about, and it was brought up before, the issue of burnout. It's about what actually stops that student as burden perception coming in, and what enhances what we do each day to want to take a student and to not head to that point that it becomes overwhelming and too much. So what educational opportunities can we offer? So the project design, we looked at, well, what's the context and where are we really at? What are staff really saying? So that was our preliminary evaluation. Was we interviewed a lot of staff, we interviewed management, we interviewed students, we looked at the reflective pieces that students put in at the end of their placements, and we analysed what common denominators were coming through in those. And that all fed into what we call a TULIP implementation plan. We're actually implementing at the moment, and so our evaluation we have some data on, but our final evaluations aren't complete at this point. As we've gone, we are looking at what each of those strategies are and what's happening in the literature as well. So we established an executive group. We have a project officer who's working with the staff and with the students. We have a course examiner that looks after the mental health subject that works very heavily within those reflective paragraphs with the students. We've got executive staff members from Director of Nursing, our head of school, a lot of people involved in that, that working group. So there's people on the ground and there's people at that higher level, so we can get things from all tiers of communication. As I said, we looked at staff surveys and interviews, and that provided some very interesting stories. We thought maybe they might be a little bit more negative than they were, but I'll show you what their feedback was. We looked at student feedback and their reflections, and the big thing coming through in the student was the fear of what do I need to know to go on a mental health placement, what am I going to be faced with, how am I going to manage that, what do I say? So that was one of their big fears. The literature, we explored that, and there is a lot of literature out there, but this looks more at that partnership approach and making individuals from the staff on the floor through to the executive management accountable, because it's an accountability trail that builds that partnership, that is, the partnership's greater than just the contract that the agreement's written on. Yeah. So that's the real impetus behind this. And then came up with the implementation plan. So the story so far, we've got staff feedback and we've disseminated that back to staff. Some were shocked at the feedback that's come globally across the health service, and Darling Downs Mental Health Service has about 15 different units. They're on 2 different campuses. There's community orientation and there's inpatient as well as, what would you call them, semi-acute to rehabilitation areas. So it covers a very, very, very broad area of mental health, from that high acute right down to rehabilitation and community care. So staff only knew what their unit had to say. They didn't know what everyone had to say, so we've collected it all together. And the outcomes of all those challenges we've communicated back. And then we asked them to look at, well, now that you know all the challenges, what do you want us to do about it? So that was the next question we put to them, and they've come up with their own implementation plan, and they're very simple strategies. And they've been included, staff have been included the entire way through. So in that consultation, we call it an as-is assessment, is what is really happening now. That's what it was all about. The managers and some of the senior staff identified that, they thought student preparedness was fairly reasonable. They thought coming into the areas, and some were forensic units, some were acute community areas, they thought they were quite well prepared, really. So there was nothing that they saw wrong with that. They did, though, see that there was a perceived lack of knowledge surrounding mental health and mental health issues. Even though all the students that go on mental health placement, their prerequisite is they must have completed that theory component satisfactorily before they go. The students will tell you everything that they'd learnt went out of their head when they saw it in the real setting. So I think that's where the disparity is there. There were communication concerns with information about placement details. So even though it came through a central portal, everyone knew when placements were on and who was coming, that information didn't seem to get to all tiers of communication. So that was good to hear. We had contact from USQ, and we make a point in the first couple of weeks of having that contact, and they really enjoyed that. We moved to the national tool, National Competency Assessment Tool, and they actually really liked that, and liked that they were able to flag problems earlier. So that came out at the same time as well. The units, what happened was we worked out that every unit had their own orientation. It all differed. There was no continuity. Everyone was putting a lot of time and effort into that orientation, but there wasn't one great ideal. There was recognition from the units that they wanted initiatives that promoted that belongingness of a student. They felt one of the biggest student anxieties was, where do I go on the first day, who's going to look after me, and where does my lunch go? And that's what Levitt-Jones talks about in all the belongingness. So that came out strong. The students appeared apprehensive. However, they felt that their staff really embraced student learning, but they wanted some greater support, and they wanted something around communication. The preceptors, multiple different ways of precepting, mentoring, facilitating. Each unit had a way of doing it their way. So one of the implementation plan strategies is looking at a whole approach. There was need for greater recognition, and I think that's part of that burden feeling of I do, but no one ever rewards that. That's certainly in the implementation plan. There was a perceived lack of positive support. They didn't seem to get the feedback back to them from the university, even though it was provided, as to how they were going as a preceptor. And they felt that there was a lack of confidence in reporting issues on performance. They felt like they'd failed the students rather than the students failing themselves, or they didn't know what else they could do. And they didn't know if they addressed something that would be addressed really quickly and timely, given that placements are a snapshot approach. The preceptor, they wanted more preceptor workshops. However, attendance was poor at the ones that were there, which suggested that maybe the content wasn't meeting what they needed. There was a willingness of staff to teach students. They really showed an interest. They really were passionate about students, and they really wanted to do a better job. And there were difficulties they perceived within that theory to practice transition. The students, number one, that perceived fear of the unknown, the lack of understanding of the type of unit. So they knew they were going to a unit, for example, called Jarrawa. They had no idea what on earth is Jarrawa and what am I going to be faced with. So unit profiles were very important to the student, and they just didn't have them. Lack of engagement, because they didn't know what the preceptor expected. So setting boundaries and expectations. A lack of understanding across interdisciplinary of what the role of the nurse was when they were with maybe a psychologist for the day. So all these things were ones that we've fed back to them that they now thought they had mastered, that they're now looking at. So that positive feedback, students loved getting the positive feedback, but the one thing they yearned for was, what do I need to improve on? And it's the one thing the preceptor felt most uncomfortable about giving the feedback on. So there was a big disparity there, that once we shared the information, the barrier came down and people shared information a lot easier. So this is our plan. It's very complex, but it's not really. It looks across learners and being prepared and motivated to teach or learn. Clinical instructors, are they prepared? And that's your preceptors on the ground. The teaching content and that relationship, and that really is that university preceptor relationship, and then the culture that supports that learning. So that's the way we constructed our implementation plan, and there's simple things in there. We've revised the orientation. It's a hands-on orientation. We've looked at ward-based orientations that are very specific, simple, to the point, but students feel loved, belonged. Preceptors don't have to worry about it as much. We've implemented a role called a clinical coach to support the preceptor who supports the student. It's about providing the staff with what they need to be able to A, do their job that they're there to do each day, but B, to be able to support students without becoming overwhelmed and overburdened. So that's the role we've put in. That coach role is not to do student assessments, it's to support preceptor to support student, and it's working brilliantly. It's also in its third year in the acute care sector, and going great guns. We're using it now for staff with performance-based concerns and things like that as well, so that's quite good. We've looked at, as I said, the unit profiles. We've looked at career pathways for RNs in that postgraduate education space. We've looked at recognition projects, and all they really wanted was someone to send them a certificate and the feedback from the student to say, this is what you really did well, thanks very much. So that's our implementation plan, which is very much in progress at the moment. We've had a few barriers. We've had closures of facilities within the project. We've had major restructure within the mental health sector. We've got a key educator that's been on secondment for most of the year, and she's our placements educator. So we've had major restrictions in that communication plan, major delays as a result. So we're at that implementation phase with some evaluation. So it's been a big 12 months. However, the staff are now hounding us to get things moving faster. So that's a positive sign. And that's the last slide, being that is my positive for the moment, is that the staff are really engaged in the project, and in the last 2 months have really come on board. They're now talking DVDs of their boundary setting and different things. So it's all starting to very much happen. The implementation plans are developed. And it's about to be launched with staff so they can see where all their feedback's gone. And staff have requested even further input, so it'll be an evolving plan, as it is at Toowoomba Hospital, where it just changes, the middle boxes just keep changing, but the outside framework remains. That partnership approach of accountability from the ground floor up is starting to evolve, and that's a really important part of making any success that's going to be sustainable, I believe. So the coach role is that pivotal communication, and that has been our vital link, and I suppose will remain our vital link for the moment. So that's our story in a nutshell, and I thank you.